Hello, this is Alfredo Castro, and this is my ARDS case presentation. Subjective. The chief complaint for this patient was dyspnea at rest and upon exertion. History of present illness, shortness of breath for 1 day, and the medical history is a 76-year-old female with hypertension, cerebrovascular accident, type 2 diabetes mellitus, and sarcoidosis. The 14-point review system turned out negative. The patient is on the following medications: metformin, lisinopril, and hydrochlorothiazide. These are for the control of diabetes and blood pressure. Objective. The patient was hypoxic with arterial saturations of 81% and room air. Oxygen saturation improved to 93% in a non-rebreathing mask running at 15 liters per minute. The first chest X-ray revealed bilateral patchy opacities without cardiomegaly, consistent with acute respiratory distress syndrome, likely secondary to viral pneumonia. The patient was intubated due to impending respiratory failure, and the post-intubation blood gas revealed a pH of 7.28, PaCO2 of 48, and PaO2 of 45. Bicarb is 20, and the saturation is 88%. Assessment. The patient met the Berlin criteria for severe ARDS, including a ratio of PaO2 to FiO2 of 75, which meet the criteria for severe ARDS. Patient tested positive for COVID-19. And repeat chest X-ray revealed worsening diffuse bilateral patchy opacities in alveolar infiltrates. Yes, the ARDS is getting worse in spite of intubation. So the plan, the patient tested positive for COVID, so the COVID pneumonia was treated with a combination of hydroxychloroquine and azithromycin. You may recall the hydroxychloroquine was somewhat controversial during the early stages of the pandemic. The acute hypoxic respiratory failure was treated with mechanical ventilation at a rate of 25 breaths per minute, tidal volume of 400, people plus 18, and 70% oxygen. And these were maxed out settings without any improvement in the oxygenation picture. In addition, the patient's renal function deteriorated despite adequate fluid resuscitation and diuretic. One thing that was noticed on arrival to the ICU that the patient was lethargic and unresponsive to verbal stimuli, even though she was receiving no sedation. The discussion of the patient continued to require more oxygen, and her unresponsiveness, despite of lack of sedation, suggested the presence of a hypoxic brain injury. Given these facts, the family agreed to withdraw care after consulting with the palliative care team, which basically stated to the family that we were in a situation of medical futility, and if the patient remained intubated, we probably would not be able to successfully extubate her. 1 week after admission, the patient received 10 milligrams of morphine and 5 milligrams of midazolam via IV push and was taken off the ventilator and expired peacefully. This case highlights a speech on which severe ARDS secondary to COVID pneumonia can progress, leading to multi-organ failure and death. In this case, this is my reference for the case. This is a case report that I used to put together this presentation. Thank you for watching.